coffee.
Oh, no, a sec. I still don't know why that's like the, so I'm just gonna have to use that one. We'll have to call, we'll have to call CPI because that all the in that box, so sorry about that. This should be fine though. They're on the screen. Yeah, okay. So
We're intimate.
we're into. So. Thank you for coming in person. Those of you who were here, pre-pandemic, we used to do frozen sessions, right? Like where I would give you a slide, or whoever was doing the session would give you a slide and you would look at it as if you were doing a frozen. So no previewing, right? No, like, we probably have some permanent follow-up for some of the cases. But Michelle helped me this time gather a bunch of BST Frozens, and I thought I think for the BST block, I think I have 3. There has 4, and there may be 1 that's kind of in the air or uncovered as of yet. So we'll see. I think we'll probably get through probably a couple sessions of this. Like if you guys like this, we'll continue to do it next time because we have a lot of cases pulled. And the second thing I wanted to say was, so it'll be today, Monday, and then Thursday of next week is when you may remember Peter Sadow from Mass General, who was on like the salivary Jeopardy with us a couple of years ago. He'll be here to teach CPP. So he's actually agreed to also come and like do a session with us Thursday morning. So we'll swap out. We'll actually do a thyroid on Thursday with him. And then we'll like do another BST and the ENT block to like make up for it here. So yeah, I figured we'll take advantage of him and yeah. And maybe if we do that one in person, maybe we can get like, I can bring breakfast or something for people. Okay, so yeah, so without further ado, I guess we'll start. And so please don't feel like embarrassed or anything. Like we're just going to talk through what you see and talk about what the clinical and radiographic differentials are, because as you know, with bone and soft tissue lesions, that's really important. And sort of how you want to communicate to the surgeon what they may or may not be looking for, right? These are practical things that we don't always like talk about, right? Like we talk about how to make a diagnosis, but you know, how do you hedge, or when do you ask, or what do you ask? And so we'll talk about all those kinds of things. So yeah, who wants to be the guinea pig?
This one is
already up there.
Yeah. So the first frozen is on. So this is the second frozen.
Okay, so we'll just start with the one frozen.
Who wants to go first?
Otherwise, I'm just gonna say you go.
Oh, come on.
Sorry. Thank you.
Okay, so I'm just gonna.
Yep. So we'll tell you, it's a 74-year-old lady. We're not going to do it Kraussian style. We'll give you clinical information. 74-year-old lady who presents with left ankle pain for 6 months, no trauma, symptoms worsen with activity, and are relieved by rest. So we'll start there, and then you'll tell us a little bit about what you're seeing.
Review, I see some like pink, maybe fibrous tissue. It's not. Also see kind of right now like spindle cells within this tissue. Spindle cells are looking a little like hyperchromatic to me. Areas of like almost like, I don't know, I even want to say like the Verocay bodies
Okay.
almost, where you
Yeah.
have like the
Kind of palisading of the nuclei.
yeah. Okay, yeah, so spindle shaped cells, I'm seeing like these varicate bodies, which makes me wonder, like, okay, so we have a spindle cell, neoplasm or proliferation right now. Where can one? Yeah. Just want to see if like cells kind of look funny. There's like a little bit like a pleomorphism, hyperchromatic. I'm not seeing any mitotic figures right now. Cell proliferation. It's like not be malignant, I think. So
Is the audio from here picking up to the people on Zoom? Because these all are supposed to be speakers, so can you just, if you text Perry and let her know if you, or is she gone?
She's here.
Oh, where are you? Okay. I was like, you're. Thank you.
so they're like in some fascicles.
Great, awesome, thank you.
Sorry.
He says audio is perfect.
Okay,
Cool.
I can see some prominent nucleoli in some cases, I think, but I still have yet to see like mitotic figures. So I'm gonna say. It's like I know what I'm talking about, but I'm gonna call a surgeon,
Uh-huh.
be like, hey, so we have an atypical spindle cell proliferation. It like most likely neural in origin, defer to permanent. Bye.
Bye. And he'll say, well, I need to know if it's benign or malignant. If they're
Okay.
gonna do this to you, they're gonna say,
Okay.
I need to know if it's benign or malignant, like give me like
Okay.
99% benign and 99% malignant. Like, I don't care if you know that, but he'll say, oh, MRI
Oh, yeah.
showed, MRI showed a mass, 2.5 centimeters. It kind of abuts the tibia. So it's in the soft tissue anterior to bone. No evidence of invasion. Radiographically,
It's been.
kind of non-specific.
I'm just gonna say it's benign.
Okay, and why do you think that?
Because I know like the cells look pleomorphic and like hyperchromatic in some areas, and I can see some nucleoli, but I'm like not seeing any mitotic figures or anything like that. So sometimes with, I don't know, like degeneration, I don't know, or like neural or spindle cells, they can have these features and still be fine.
Right, so one of the most important things I think that you picked up on early on was that kind of palisading of the cells that was suggestive of maybe a Schwannian tumor or a schwannoma. You picked up on the absence of mitoses, which is really important, right? The absence of necrosis, and the concept that if you think that this could be a nerve sheath tumor, especially with the wavy nuclei, especially with the palisading, that some amount of smudgy or degenerative or ancient type of change is acceptable in nerve sheath tumors. So yeah, this was actually called schwannoma with ancient change on the Frozen. And I'll give you a slide of the resection. So then they're like, okay, cool, we'll take it out. And I'm happy to, maybe if you guys want to have these as record, we can scan them. We can maybe scan a Frozen and then a permanent, just so the cases will be available for people to review later, since they didn't get it. You all might want to look at them on your own, right? So I would focus on the screen.
Like relatively. If it's necrosis or just like blood, like extravasated blood.
Yeah.
that's fine. So that helps like with the degenerating aspect. There's some like hemosiderin.
Oh yeah, there's really nice like palisading here with this pink fibrillary matrix kind of in between. So yeah.
It's more like the Veracay bodies, like, and it's like what is Antony A, Antony B. I
Yeah,
don't know, it's
basically
like,
more cellular areas and less cellular areas. It's still blurry.
areas where it's like, yeah, hypocellular and then have like the hypercellular,
Right.
but I still don't see like mitoses or anything.
You shouldn't. You
So it's
shouldn't.
like, yeah, and then so ancient schwannoma.
Ancient schwannoma. And so things to remember about nerve sheath tumors, right, are kind of wavy nuclei. For schwannomas, you'll have the palisading in the Veracay bodies. You'll have over there was some hyalinized blood vessels that were, oh yeah, these are perfect for schwannoma, right? Those are great. And then in schwannomas with ancient change, that degenerative smudgy atypia without, you know, prominent nucleoli or without mitoses. It's sort of just like a dark kind of smudge. So yeah, is that good for everybody for now?
Thank you.
Awesome. It wasn't so bad. Right, who's next? Are we just gonna go around the room? I'm gonna make all the first years go because, you know, get it over with. Just Band-Aid. Band-Aid. This is a 79-year-old female. So I'll give you some time to think about it while I read you the history. 79-year-old female that presents with knee pain. She has noticed a mass along the lateral knee for quote unquote a long time. And it turns out that it is, so Dr. Hayden comes up, down, I guess. When the gross room was over here and the ORs were below us, surgeons would always come up. And so I'm always like, the surgeons are always coming up to the gross room. You guys are like, no, the surgeons are coming down because now the ORs are above the gross room. So I get my head all turned around. So anyway, okay, the surgeon comes down and he tells you, oh, it's in the femur, it's in the distal femoral metaphysis, right? So what's metaphysis as opposed to diaphysis or epiphysis?
Between diaphysis and
Stalk metaphysis like this is the little tippy tip, right? So in growing bones, she's, you know, an older lady, right? The epiphysis is sort of like the growth plate region. And then when bone matures, the epiphysis at each tip of the bone closes, and then it sort of bridges into the metaphysis, and the diaphysis is the shaft, right? So this is kind of at the angular portion, okay? And there's no cortical destruction. There's no additional lesions. So it's solitary. What we know right now. It's a little out of focus on the screen. There we go. And if it's dirty, I'm sorry, you can wipe the slide off.
Overall on low power, it's not a terribly cellular lesion. We just kind of have fragments of it's like collagenous looking stroma or like elastin like. Like I said, not terribly cellular, kind of similar to the last one in the sense that you don't really see mitotic figures or hemorrhage or necrosis, nothing like that. The cells are almost like I mean they're spindled for sure.
Oh, it's a little blurry.
there's not really much pleomorphism to them. The nuclei are very small.
Solid, stroma, or it's just like
I don't think so.
I mean, there's definitely, right, there's space between the collagen. It could be edema. It's sort of mixed. So I mean, edema / myxoid are sometimes interchangeable. I don't see like mucin, right, per se.
Are there mouth cells?
Really?
So for this one, I'm gonna say that this is a benign lesion.
Mhm.
And based upon the background, like two things that would be in my differential
Mhm.
would be like a spindle cell lipoma or an elastofibroma.
Okay.
So,
Okay, go, cool, benign, awesome, thank you. So yeah, I think we can all agree that, you know, the features of this are maybe not diagnostic of a particular thing, like the schwannoma was a little bit more suggestive of itself. This is like, I don't know, bland, probably fibroblast or myofibroblast-like cells in collagen, very paucicellular, so benign spindle cell collagenous thing, I think is totally appropriate, and this was called, yeah, bland spindle cell process, period. So. As you guys get through, cases, right, you'll see some people are more wordy and some people are less wordy, and my vote is be less wordy. Like, the more you pigeonhole yourself into something specific, sometimes the more you put your foot in your mouth. So, yeah, benign spindle cell lesion, fine.
this area may be a little bit more cellular than the frozen.
Still these kind of wispy, like bipolar cells, right, with kind of compressed nuclei. So again, kind of a fibroblastic, myofibroblastic type of cell, as opposed to the nerve sheath cell that we just saw.
I don't think I necessarily see features that are diagnostic for anything in particular, so I would probably do some stains on this one.
Okay.
most muscle
I
active.
was thinking again, like, just because of the background, I was thinking like an elastofibroma, so I do an elastin stain on it.
So where are elastofibromas usually located?
On the back, right back.
Yeah, so they're usually between the scapula and the chest wall. So this is not really the right location for it. I mean, that's pretty much the only place you really see them. So I probably wouldn't weigh that too highly. And you can see elastin on H&E as like thick purple kind of bands, which we don't really see here either. So there was not an elastin stain done on this, but it would have been negative.
So maybe like
Most muscle active, CD34,
Okay, for what purpose?
myofibroblast.
Okay, so you want to see if these are fibroblasts, myofibroblasts, and sometimes they express myogenic markers like SMA. It certainly doesn't look like smooth muscle, right? It doesn't look like a leiomyo something. So we'd be dealing with a myofibroblastic process, if anything. And remember that SMA always normally, what does SMA normally stain that we're seeing here? What cell in the vessel?
Muscles.
What specific subtype of myoid cell? So we're in a capillary, right? Yeah, so pericytes are perivascular myoid cells, right? So if you're in an actual like artery or vein, like yes, then you're actually seeing a smooth muscular wall of the artery or the vein. But if you're in a tiny cell like a capillary, you can actually see the endothelial nucleus, right, is like negative. But then the cells around the endothelial cell, which are the pericytes, are positive. And sometimes you don't even, when you look at a capillary, like you might not even see it on H&E, but you can see it on SMA. So, okay, so the pericytes. I love helium to like walk around with you.
Once in an SMA.
I was ESN and my friend Maria was hematoxin and we just walked around in pink and purple all day. It was pretty fun. Okay, all right, sorry, off the topic. Sorry, guys. Okay, so are the actual tumor cells staining with SMA?
No.
Not really, okay. So then we are on the more of the fibroblast as opposed to the myofibroblast type of spectrum. Is there anything else you want to rule out since these are SMA negative?
It's 100.
Okay. Yeah, so not nerve sheath either. So yeah, so we're basically dealing with a benign fibroblastic circumscribed lesion. So some kind of collagenous fibroma, I think it was called some kind of fibroma. So, you know, it's not a very satisfying diagnosis to call something a fibroma, but at least you've given the patient a benign answer and it's cool. Comments, questions? See, well done. Flipping the opposite direction of the ones that we're seeing on. Cool, thank you. All right. Next. I don't know. This one looks like it has a little bit bigger tissue. Oh no, that's not a file. Yeah. That's 1195. All right, the patient is a 43-year-old female who has a history of a right tibial tubercle osteotomy in 1992. She has progressively worsening pain in the calf for the past 6 months. She denies deep bone pain. Pain is worse with activity, and she would be pain.
How old was she?
Ooh, 43.
And how long have you been going on? Sorry, I was just.
No worries. Progressively worsening 6 months. Worsening 6 months. Okay. It's so bad.
Is there a max?
There's abnormal signal intensity on MRI within the proximal tibia. That is about 13 centimeters they measured, so pretty big. So good question, right? When you are looking at these Frozens, if the surgeon is not there to help you, or your trusty, resident hasn't found the imaging findings on the municipal pre-op sheet, like go in and look at the imaging findings for something like this. And so the MRI says the tumor breaches the cortex posteriorly and has a soft tissue component. It's diffusely contrast enhancing. So sounds worrisome, right? All those radiographic features start to sound worrisome.
So is all these areas with like basically no cells here, like just being sort of like surrounding reactive change, then there's areas like here and over here which get me worried. Where you have those like equally good. Yeah. No.
Now
It's
the-
really large
ahead.
irregular nuclei.
Mhm.
It's kind of like very fluffy stroma. Seeing very many mitoses in the section. Not sure if these are very atypical mitoses or but there's my link right there.
I don't see it.
Closer. There. Is that kind of like a chasm? between the parts of
I'm
the
not
neighborhood?
sure.
Okay.
Not convinced. It doesn't have jazz fingers.
Yeah, so I'd say this is based on these really ugly looking nuclei. And like, not only that, but just like kind of like patches of them. So it says both bone and soft tissue component. I hazard a guess that maybe this is from soft tissue invading into bone.
It sort of depends on the epicenter. It looks like here the epicenter is potentially in the bone
It's in the bone.
and it's extending into soft tissue, which would be fine for, you know, the opposite. Soft, a bone sarcoma with soft tissue extension, but yeah, so the most important concept for bone is to not undercall something as benign, right? And so if it's overtly malignant and you can say, yes, this is overtly malignant, they stop, right? They stop. They will pack it and deal with it later. If you call it benign, they will curette it, right? And contaminate the field, and they can no longer treat the patient with limb sparing surgery, right? So they have to basically, yeah, that's pretty hypercellular.
Yeah.
They can do, they would have to proceed more with like an amputation type of surgical procedure rather than a bone, like an internal bone resection. So if you ever are unsure, on a frozen of bone, whether it's benign or malignant, right? Have a discussion. And if you have a nice surgeon and you say, I'm not sure, like this could be malignant, they'll stop, right? And they will not contaminate the field. So radiographic impression along with your histologic impression are really helpful. And so we've had cases of highly atypical, like chondromyxoid fibromas, for example, that like we just couldn't tell that they weren't malignant. You say, I don't know, like I'm not a hero, but you know, don't be a hero, and stand your ground if you don't know. But if you like this are pretty convinced it's malignant, then fine, you don't have to hedge, right? But
I'm also like appreciating now, like, it seems like there's kind of like this internal septation. So there's this hyper kind of eosinophilic areas and there's more
Yeah.
myxoid components kind of like, they're interwoven together.
sort of like fasciculated.
Yeah. Wondering, yeah, if that's like kind of a dedifferentiated chondroma, like kind of form, kind of like more like a bony matrix or some sort of matrix or.
So I'm not sure I see matrix per se. I think you're probably just seeing intersecting spindle cell fascicles
Oh, just
where
intersecting
you get a
fascicles.
little bit of pallor between the fascicles. I don't necessarily see like osteoid or chondroid matrix. I see more fascicles. So
Spindle cell neoplasm.
spindle cell neoplasm malignant.
Yeah.
Great. It was called malignant spindle cell neoplasm. And if you want to follow up on the permanent, I can give you some things. Since we have them. So that's a non-frozen piece of tissue. So they did, in this case, they took a little more for diagnosis and immunos and molecular and whatever, and that's it. So we have a part B with more information.
Yeah. It's same thing, same like these like little areas where there's cells.
Yeah, so can you go on higher power in one of these areas for a second? I want to
Maybe-
see.
Oh, it might just be necrosis.
That's my question. Is it necrosis?
Yeah.
So if you start to
Oh,
see
yeah.
ghosts
So
of
this is
ghosts of
necrotic,
nuclei,
yeah.
yeah.
It might just be burned out tumor.
So that's another, if you're seeing necrosis, it's something that is previously untouched, right? Like then that's probably true necrosis. If you see necrosis and patient's already had a biopsy, then you kind of, okay, maybe step back a little bit. In this case, I wouldn't consider the frozen enough of a biopsy to like cause necrosis immediately in the next door tissue, right?
Yeah,
So
yeah.
like,
It's probably the worst
yeah, okay, cool.
there.
See.
Yeah, so I'm wondering if this is adjacent area or actually doesn't look too necrotic. There's still nuclei in there, though they're small.
Do you think that bone is being produced by the tumor or being entrapped by it?
I don't see any osteoblastic rimmings in my eye.
Okay,
And it's already kind of like very well organized bone, not kind of like this dystrophic bone. So I think it's probably entrapped.
yeah, so you don't see osteoblast rimming probably because it's dead bone.
Yeah.
It doesn't have osteocytes in the lacunae either.
Yeah,
The fact that it has lamellae and is mature, as you said, basically implies that this is pre-existing mature lamellar bone that's being entrapped by tumor. So that's also a really good sign of malignancy in bone lesions, right? So if things push aside bone, right, that's more benign. If things entrap bone, that's more malignant. And if things produce the bone, then you have to ask yourself, are the cells that are producing the bone benign or the cells that are producing the bone malignant? And things like osteoblast rimming, nuclear hyperchromasia, et cetera, can be helpful for that differential. But in this case, it's basically entrapping bone and killing it. So yes.
yeah, to my eye though, I don't really see any morphologic features beyond what I would appreciate in the frozen.
Yeah.
That could point me to a specific diagnosis.
Yeah. So basically malignant spindle cell neoplasm is some kind of high-grade sarcoma, right? Some kind of sarcoma. We don't see evidence of differentiation necessarily into nerve sheath or right? It's not producing bone, so it's not osteosarcoma. So I think if you're curious, I think they did a number of stains that showed, if you want to see, I could show you a little bit of positivity for SMA and calponin. So again, with some kind of maybe fibroblastic, myofibroblastic, or even smooth muscle differentiation, but beyond that, nothing. So high-grade sarcoma with myogenic differentiation was the bottom line on this case. Yeah, so there's some SMA.
Pretty good.
There's
Is the areas that are not SMA positive just look like it's actually just there's just less cells there.
right.
And within these cellular areas, it's almost 100%. Let's say strong.
So in order to call something true leiomyosarcoma, you want the morphology of smooth muscle, right?
Yeah.
You want long pink fascicles. And if it were a leiomyosarcoma and it started to get more differentiated, you might lose some of that fasciculated morphology.
Yeah.
So this was just called differential includes leiomyosarcoma versus myofibroblastic type of sarcoma, but it's high grade and it's not osteosarc, right? So that's kind of the most important thing. It's a high grade sarcoma and it's not osteosarc because they potentially will treat osteosarc differently than non-osteosarc. Okay. Awesome job.
Thanks.
Yeah. All right. Next. Definitely gonna need all the sections for this one. Okay. Thank you. Okay, 36-year-old male. Left wrist pain, 6 months. He works as a laborer in a steel factory and he thought his wrist pain was just overuse. They get an imaging of his wrist and there's a lesion in the distal ulna.
No power, it looked very cellular.
Came from steel mill.
cellular spindle cell cell. Microbiotic. So it could be something that would be useful.
Yeah, the bone here is not quite as overtly mature, right? So.
Is the process my target picture. Fairly similar in size and shape. This area is very cells are very chromatic, hyperchromatic, artifact. Very close. Waiting, but I don't think it's to nerve sheet.
Okay.
Exactly any clear pattern that I
Do we have giant cells or
don't see giants.
What were you thinking?
something ossifying like fibroma, not just like something like this?
Because of that little piece of bone? I see.
Clearing halo around the
Might. But vessels are kind of like hard.
So you're thinking solitary fibrous tumor? Okay. Like those, yeah, those are vessels there. Okay. Is it, is the cellularity and the level of cellularity and the level of atypia, is that okay for SFT?
It's more.
It's more.
It's more. It's very busy.
Yeah. So, all right, Rex Hayden is calling you. Minor malignant.
Seem this is not in bone output. I wish I could put borderline, but
Malignant.
it
Yes.
could be.
Mhm.
Could be. There's some.
Okay, if you're worried at all that it could be malignant, then you have to say, it could be malignant, I'm worried, stop, right?
Say spindle cell, neoplasm, subsistent, suspicious for malignant.
There you go, there you go. And he'll say, cool, yeah, because, you know, the MRI actually showed that there was cortical destruction within this distal ulnar lesion. So if you're thinking that it could be malignant, it looks like it's malignant on imaging. So I'm just gonna give you some more tissue and stop there. Great.
Was it called slam dunk malignant on Frozen, or was it?
It was called malignant spindle cell neoplasm. And so, you know, I think honestly, the level of hypercellularity and the level of hyperchromasia and pleomorphism is a little much. And without, I mean, I didn't go around and search for mitoses here, but chances are you'll probably find them. But we'll give you guys these slides for your own. Go over them with a fine tooth comb and convince yourself, but, yes, it was called malignant. Yeah, it's a little hard on the scope, so, oh, there's no HDP one. I don't know why we don't have it. So they did an extensive workup on the permanent here. One thing I wanted to show you, because we're talking about bone production, right? And is this thing producing bone? If so, could it be osteosarc? If it's not producing bone, then is it against kind of fibroblastic, myofibroblastic sarcoma? They're the best, I don't know if we're gonna have an osteosarc today, but we will eventually. So the best way to determine whether something is producing bone is by imaging findings as well, radiographically, as well as by the production of osteoid by tumor cells, not just woven bone or calcified matrix, but actually homogeneous pink osteoid. And we'll see that at some point in the next few weeks. But there's one immunostain that yeah, maybe flip the condenser, that has been purported as demonstrating evidence of osteoblastic differentiation. Does anybody know what it is, what we're looking at? No. SADB2. So SADB2 was originally, you guys use it in GI for something?
CRC.
Okay. Okay, what does it do there?
It's positive in colorectal.
Okay, better than CDX2?
Supposed to.
Supposed to be.
A magic bullet.
Magic bullet, when it, just like this was the magic bullet for osteoid.
Not an-
And then people are like, oh wait, SADB2 is positive in all these other sarcomas, so forget it. But at the time, SADB2 was done. This was in 2021, but it was done, I think, by. So it was suggested by Rosenberg. I'm not entirely sure why. Maybe it, even back in 2021, I think it was pretty well known that this was not a great marker. I think if it were negative, it would support that it's absolutely not osteosarcoma. But if it's positive, then like, okay, we don't know, then you have to look for osteoid stuff. So don't rely on SADB2. You might read about it there in the literature. Don't rely on SADB2 as a confirmation of osteosarcoma, because at least in this case itself, there was no evidence of actual osteoid production by tumor cells. And look how strong the SADB2 is. So it's kind of a pitfall, but as long as you know how to interpret the stain, like negative is helpful for not, but positive is useless.
It's useless.
It's
Just
useless.
kidding.
But thanks for showing us useless stain. Awesome. Comments, questions? Does anybody want to see anything else on this case? They did a whole bunch of things, none of which were very helpful.
How did they word it?
What?
What the final?
Oh, it's high-grade spindle cell sarcoma. With focal myofibroblastic differentiation, because there was, again, some SMA. The other things you want to think about in bone is when you have a spindle cell sarcoma, intraosseous, that you're not sure if it's making its own osteoid or not, you could think about a fibroblastic osteosarc, right? We were talking about the 3 variants of osteosarcoma, chondroblastic, osteoblastic, and fibroblastic. And so the fibroblastic ones are predominantly spindle cells, but the fibroblastic osteosarcomas of bone tend to have amplification of MDM2 and CDK4, just like liposarc. So they did MDM2 and CDK4 here. That's right. Did MDM2 and CDK4 here to prove if this could or could not be a high-grade transformation of a lower grade fibroblastic osteosarc and it was negative. So at least we can say, okay, it's not a fibroblastic osteosarc also.
Actually, not a radiology, you're
Yeah.
looking for osteoid, is it like, that's how they actually report it, or there's a correlate?
So they'll report it as mineralization. They'll usually report it as there's internal mineralization, calcification, stipple, blah, blah, blah. They usually don't say osteoid per se, because they can't see that microscopically, right? We can say it's osteoid, it's woven bone, it's lamellar bone, right? They can just say, oh, it's mineralized.
Yeah.
That's usually the word that they use.
Oh, I have a question, I guess,
Yes.
is there a diff? I mean, other than like high grade spindle cell, like. I guess when would you call something like a fibrosarcoma? Like if it has,
So it, I'm not sure that people believe that fibrosarcoma is a thing.
okay, I was like,
So-
what is, okay.
So, I have to check the WHO to see if fibrosarcoma of bone is still a thing. It was at some point. Can you check? So
Yeah,
the,
it's still on here.
yeah, no, people don't really use that term. I think
Okay.
it's a Fletcherism, but, but. Anyway, Chris Fletcher is a soft tissue pathologist. Anyway, so fortunately or unfortunately, the nomenclature of sarcomas in bone and soft tissue isn't always uniform. And so I tend to use the more soft tissue terminology because I think it kind of makes more sense. So like there's undifferentiated, formally undifferentiated pleomorphic sarcoma, which is not just undifferentiated sarcoma, it was just a high grade sarcoma. That would basically be fibrosarcoma of bone, right? It's basically a high grade spindle cell sarcoma that you can prove is absolutely nothing else. It's not osteo, it's not lipo, it's not lyo, whatever. Then they call it, well, what is a spindle cell that expresses nothing? A fibroblast, right? So fibrosarcoma. So technically, just an undifferentiated spindle cell sarcoma of soft tissue or of bone or whatever is like kind of by default could be construed in one's brain as a fibrosarcoma because it is thought to be a fibroblast. But who knows? Like, I don't know, you know? So,
Yeah, right here it says diagnosis is one of exclusion.
right.
Okay.
right. So I think if you called this a fibrosarcoma of bone, you wouldn't be wrong, but I think a lot of people don't use that terminology because it's a little too weighty, like, it's just an undifferentiated, it's just undifferentiated sarcoma.
What about UPS then? Like when-
Yeah, so undifferentiated pleomorphic sarcoma, UPS, which is now just undifferentiated sarcoma of soft tissue, is the same, it's conceptually the same.
Okay.
It's conceptually the same. Well, the term fibrosarcoma isn't used in soft tissue. It's just undifferentiated sarcoma. The only time fibrosarcoma is used in soft tissue is two places. Where are the two places where we actually use the term fibrosarcoma in soft tissue? In children, okay, in infantile fibrosarcoma that has the ETV6 and TRAC3 rearrangement, it's like these long, very hypercellular herringbone fascicles, right? And what's the other? So it's definitionally infantile fibrosarcoma with this rearrangement. And then the other fibrosarcoma is fibrosarcoma is transformation of a DFSP that looks the same. It's got long herringbone fascicles, very hypercellular, and it retains the collagen PDGF, the whatever fusion of a DFSP. So it's provable, right? It's provable. Otherwise, it's just undifferentiated sarcoma. Questions you have?
It's a surgery diagnosis.
What?
It's a surgery diagnosis.
What
Right, you
is?
can't call it on a biopsy. You have to get the surgery specimen to allow that you don't have like a differentiated group or something else. Or you could actually make this diagnosis. on biopsy.
What diagnosis?
Undifferentiated sarcoma.
Oh. Yeah, you can make all attempts to make a diagnosis of undifferentiated sarcoma on a biopsy, and usually we can because you can rule out other differentiation in many ways. You can rule out, for example, liposarcoma by MDM2. You can rule out fibroblastic osteosarcoma by MDM2. You can you can sometimes rule out other things by genetics, but you can more often rule them out by morphology and just immunoprofile, right? And so, yes, you may ask, oh, well, is there sampling error? There might be, but you kind of have to take everything into context, right? Like, is there a secondary area on imaging that maybe you haven't sampled, right? Or is this coming from the sacrococcygeal area, and they say that on imaging there's looks like what could be a chordoma, and then you can say, oh, maybe this is a D. diff chordoma, and then you'll do brachyury, right? So you really have to take everything into context. But if it's a homogeneous tumor, there's no other morphologic, immunophenotypic, or genetic, you can just say undifferentiated sarcoma on biopsy, or you can say high-grade spindle cell sarcoma, see comment, like probably undifferentiated sarcoma. Usually, more often than not, like it is what it is. I think we're at 8:59, so probably not enough time for another case. But if you guys like this format, then we'll just do it again on Monday. And everybody who went today, you're great.
Yeah, I think we're gonna do this, yeah. Yeah.
One second.